Aloha, Kayaka, and welcome to Cardiovascular Health. This is week 1, so we're going to talk about just basics of clinical exercise testing and basic interpretation. So as you know, I'm based up here at the Gold Coast, so Neil will be conducting the toots down in Lismore. Remember, Neil, he's actually completing his PhD with us, but he's got an academic position at Bond. So he's only going to be available certain days of the week, but you'll be able to contact him. Send him an email, or when you're there for your toots or PBLs, whatever, you can make arrangements if you need to meet with him. Of course, you can always ring me and we can Zoom or Skype or whatever. So I put this up. This isn't, you don't have to worry about anything about these slides. This is in for ESSA requirements, so they know what basically we're targeting in each particular lecture and unit of study. So what about the assessment? So you're going to do an ECG rhythm generator quiz. So that'll be MP4. I'll just bring up an example. Give me a second. All right, sorry about that. So the ECG quiz, oh, that's right, I was going to show you the, okay, hopefully you can see this. So this is what it's like. So this is one of the example ones that you'll get. So this is second degree AV block type 1. It's known as Winky block. You'll learn that, but anyhow. So you've got these, when you do your exam, you'll see that I've recorded probably about 30 seconds or so. And when it gets to the end, all you have to do is hit play again. So you can do that, and it'll keep running through. Now, and then there'll be a mini-OSCE. That's only an SR requirement, so satisfy requirement. And you'll do that in group, whether it's 2 in a group, 3 in a group, etc. Will depend again upon student numbers. And then the final exam. Now, it's important, I said this in the greeting that I did for you the other day, your final exam will be held in the exam period, but it will not be listed on the exam timetable. All right, so we'll talk about that as time's coming up to sit it. So for this unit of study, based on feedback from last year's students, so you've got lectures that are online and recorded, obviously this, then you've got your labs and toots, PBLs, whatever we're doing that you'll come on campus for face-to-face. But the students wanted additional learning support, etc. So what I'm going to do is I'm going to run PBL, problem-based learning, sessions with you. We'll pick the day and time that suits all of you, but to participate you have to have a microphone at least, so you can talk, because it was ridiculous last year with the amount of time people trying to type, etc. Now remember, Zoom is available as an app, so you can always just call in on your phone, etc. And a webcam is the best. They're so inexpensive, and basically they've got microphones built into them. So ECG basics, again, it's recommended that you review the basics of simple ECG. So Dubin's rapid interpretation is really good for doing that. And if not, I've given you some links here for some of the other books. And I'm pretty sure that in your content, I've uploaded an ECG book for you that you can keep. So this is just a list of the arrhythmias that we'll go through, you know, ectopics, all the way down to your AV blocks, first, second, and third degree, etc. So attendance, remember that SCU Health Sciences has a policy for clinicians in training, which all of you are. So basically all MSEP students have to attend all TOOTS labs and seminars in this unit. That's the face-to-face component. If you, for whatever reason, have to miss a face-to-face lab, unfortunately, we can't repeat labs. And you're to notify, if you're down in Lismore, you notify Neil. If you're up here at the Gold Coast, you notify me. It has to be beforehand, because if it's after it's occurred, then it's an unexcused absence. So I've already got that. So prax toots, this is just, you can go through this on your own. What we'll do going through, you can see the clinical skills assessments listed, and again, that will depend upon how many students are in the class. So learning outcomes, you can go through those, basically what you'll learn going through this lecture. And let's get started. All right, so clinical exercise testing. So you're going to see in the literature that it's either called ET exercise testing, CPAP, cardiopulmonary exercise testing is a little bit different. Simply all they're doing there is they're also collecting expired glasses. It can also be called ETT, exercise tolerance testing. For general purposes in this unit of study, I'll always refer to it as a GXT, a graded exercise test. So in this unit, you'll utilize knowledge attained from your undergraduate degree. So you need to know what are normal resting values, heart rate, blood pressure, ventilation, etc. What's the normal responses to exercise? Again, heart rate, blood pressure. What are the post-exercise responses? And that's with particular emphasis on heart rate, blood pressure, ECG, oxygen saturations, and rating of perceived exertion or rating of perceived dyspnea. So, graded exercise testing. So it's primarily used in the diagnosis list of possible diseases, conditions that could be causing that for cardiovascular disease. And it's also very useful in determining disease severity. So let me stop there now and just right from the beginning tell you that we'll teach you while you're here in the program, you will only do submax graded exercise tests. The highest you'll go is to 85% of an age predicted max. Obviously, it's going to be a little different if they're on a beta blocker, etc. I highly recommend to you in practice that you only do submax testing. If you go through the ACSM guidelines, you'll see that either 1 in 10,000 or 1 in 20,000 individuals will die doing a stress test. You have to appreciate that there's a small percentage of the population which are asymptomatic, but they've got cardiovascular disease. So essentially, they're an accident waiting to happen. Now, during the stress test, the patients are monitored while performing it using standard protocols. Tests are either subject limited, basically it's called volitional exhaustion. The patient goes, they want to stop, or it's symptom limited. And that's where you either see an arrhythmia or ST segment changes on the ECG. There's a irregular blood pressure response. They complain of chest discomfort, tightness, angina, etc., fatigue, and you stop it. So every test that you do is either subject limited or symptom limited, and that goes in your GP and specialist report. So I talked about CPAT. So the important difference is that CPAT is traditionally a graded exercise test with expired gases. So you did that testing in your undergraduate degree. I cannot name one AEP in practice who has a set of analyzers. They're just too expensive. There's no Medicare item number that you can charge against. So it's very unrealistic. So any time you test a patient, you need to basically be able to predict or estimate their VO2, which is, as you'll see here, is listed as PVO2, predicted VO2. So I'll go back one. And also, it's usually PVO2 peak, not max, because we're only estimating it. So what are the different stages for exercise testing? So stage 1, and really that's what you'll do. So that's where it's symptom limited, non-invasive measurements, ECG, blood pressure, ventilation. We're not going to do expired oxygen and CO2. You will do pulse oximetry, etc. So most clinical tests that you'll do, whether it's patient or athletes, it's a stage 1 test. Stage 2 and 3 are more complex. Stage 4 is highly invasive, and that's where it's basically right heart catheterization. Now, this is the ACSM pre-screening. We're just going to review this because now you're dealing with patients with disease or suspected disease. So if we just go through it real quick, no cardiovascular, metabolic, or renal disease, no signs or symptoms, medical clearance is not necessary, and that's the recommended general by ACSM intensity guidelines. If they've got known disease and they're asymptomatic, doesn't matter, medical clearance. And then that. If there's any signs or symptoms, and I've got a case study with a patient that I'll give you later, again, medical clearance. Years ago when I first came to Australia, it wasn't very litigious. It is now. So God forbid you get a patient, you do a test on them, and you don't have a medical referral, because I teach you in this program, patients lie to varying degrees. Typically males more than females, but I've had females tell lies that could have been very costly to them. Anyhow, so make sure you get a referral, because that's the GP saying this person is safe to participate in exercise. And again, as I mentioned, I stress only submax graded exercise tests. So on here, if we look at it again, any signs, symptoms, if they're in regular exercise, they stop exercise. Somebody comes and go, oh, look, I'm getting breathlessness at a low intensity of work, etc. Don't test them, send them back to their GP to get a referral to see you. And the GP may send them off to get a stress test, a full 12-lead max stress test by a cardiologist or at their local hospital. So what are you monitoring during your submax test? So ECG monitored continuously, heart rate monitored continuously through the ECG, blood pressure monitored continuously. You'll learn that, for example, in the Bruce protocol, it's 3-minute stages. So you'll always take a blood pressure at the end of those stages. If it takes you 30 seconds to get a blood pressure, then at 2 minutes, 30 seconds, you're going to start your blood pressure. Signs and symptoms, again, monitor continuously and record, and certain signs and symptoms may be indicative that you need to terminate the test. And I've got that slides for you later in this lecture. And RPE. So I use the 1 to 10 scale, that's Borg scale. You can use the 6 to 20. My experience is that older patients don't get 6 to 20. So in principle, the reason the new one was developed is that if you take somebody who rates it as a 7, you add a 0 behind it, and their heart rate should be 70. And the same thing, if they rate at 15, it should be 150. Patients just don't get it. I just go with the 1 to 10. But whatever you use, you have to use continuously. And again, you'll monitor these before the test to make sure they're able to do the test. There's nothing sinister during the test, and then post-exercise into recovery. Now, these are other scales that you'll use. You can see on the top the angina scale, 1 to 4. Claudication scale, that's for patients with peripheral vascular disease. And remember with the claudication scale, and we'll talk about this more in one of your other units, or we can discuss it during one of the PBL sessions. You have time of onset that they say they feel it, and then the time that you have to stop a test or an exercise session because of the pain. Because remember, your patients with PVD, which can be cardiac patients, they can be diabetic patients, etc., they're going to do intermittent exercise training. And then dyspnea scale. So this is the normal Borg scale. I told you I use the 1 to 10 scale. And we spoke about angina, claudication, dyspnea scale. So going back to your undergraduate degree, you need to be able to know the normal responses to exercise. So remember, the normal response, there's a linear relationship or increase relative to the exercise intensity. When they get up to heart rate max, it obviously plateaus out, etc. Now, what's abnormal? Basically, if a patient can't reach 85% of their age-predicted heart rate max, it's referred to as chronotropic incompetence. And obviously, there's something wrong somewhere. You may also get patients that can exceed 220 minus their age. However, you won't be doing any max testing. With regards to recovery, so even if they're a Homer Simpson, when you put them down into recovery, so you've dropped the treadmill speed and grade or the watts on the bike, the heart rate should go down. There's a heap of studies that are out there, and basically you want to see at minimum 12 beats per minute in the first minute or drop by at least 22 minutes. And the key here is active recovery, meaning they're still walking or still cycling. Now, bradycardic. So athletes, you're used to dealing with fit people, and probably most all of you have heart rates below 60 beats per minute, that's bradycardia. But Kamerling proposed the following type. So there's mild, which is 50 to 59, moderate 40 to 49, and severe. Now, sure, can you see elite triathletes, cross-country skiers, etc., that have 40 beats per minute, they're in normal sinus rhythm, etc.? Absolutely. But if you get patients, you still record it. What I do is I just put bradycardic. I don't list it according to this. I just list it, but it is there for you if you choose to do so. So here's a case study. So Brady's one of my cardiac patients. He had a stent to his left anterior descending 5 years ago. So I did a submax stress test on him on the cycloergometer, just a Monarch, mechanically brake Monarch. He got up to 75 watts on the bike. His peak heart rate was 129, and it was regular. Blood pressure hit about 182/94, which is still a normal response. He had no complaints of shortness of breath or chest pain. Now, as I mentioned, he was monitored with a Polar heart rate monitor. I don't own any stock in Polar, but I think they're the best. The literature shows they tend to be the closest in accuracy in terms of ECG. Seated after the test, I always leave the sound on. And the heart rate, the watch, so I've now taken it off his wrist, but it's just on the edge of my desk. That's so they don't go home with it. And it looks like 96, but the beep is actually much slower. So I turned the watch around, and it turned out he was something like 36 or whatever. Anyhow, stopped everything there, sent him to his GP, reported, turned out he did have a heart block. So we'll talk more about that in the PBL session. By the way, those PBL sessions will be for every week, except for week 6 when you have your midterm. So what about the normal blood pressure response? So again, we know that with aerobic exercise, systolic increases relative to the intensity of the exercise, diastolic stays basically the same. And down on the bottom graph, what we can do is see that the workload is increased, and we can see systolic blood pressure going up, and then this doesn't show any recovery, and we can see diastolic with just a slight increase, and then just going down a little bit, and that's fine, that's normal. Now, post-exercise, there's a progressive decline in systolic blood pressure. Basically, we want to avoid peripheral pooling, and that's what I mean by keeping their legs going, whether they're on a treadmill or they're on a bike. So in this study shown here, you can see that after 4 minutes of exercise, you can see systolic peaked in older individuals at about 160 millimeters of mercury and about 140 in the younger. But notice that as soon as the exercise stopped, but they were in active recovery, you can see how it's gradually working back down towards its initial resting value. Now, what's an abnormal blood pressure response? If you get a drop in systolic blood pressure with increasing workload, huge problem. And that's why it's so important that you can measure an accurate blood pressure. So during rest, that's fairly easy. During exercise, particularly on a treadmill, you'll learn the skill. I see students stress every year. Don't panic, you will learn it. If blood pressure doesn't increase with the workload, again, it's a problem. What you're thinking, you're not thinking it, but they're starting to wonder if the person has an aortic aneurysm, or if there's an excessive blood pressure response, i.e. systolic over 250 or diastolic rises over 115. So rate pressure product, you learn this, it's called double product. You may have learned it as it's heart rate times systolic blood pressure, but clinically it's used to quantify what's called the ischemic threshold. So basically, if a patient is in, let's say a cardiologist getting a max stress test, and they say, oh, they're getting some chest discomfort, the cardiologist looks over on the screen and sees some ST segment changes, he'll tell the nurse, take a blood pressure real quick, and they'll tell you what that rate pressure product is, and then you'll train the patient under that rate pressure product. So what is important about rate pressure product as well, let's just say that here the patient is getting, we'll just use the heart rate and assuming blood pressure is the same, that's 160. The patient, as you can see, works up to that workload, so let's just call it treadmill speed. If you train them, Because with exercise training, aerobic exercise training, it lowers heart rate and blood pressure at each stage as well as at rest. It shifts the rate pressure product to the right, which is highly favorable. So let's just say initially the person started to go ischemic at 5 kilometers an hour. Now with exercise training, they can work up to 8 kilometers an hour. So it's hugely important to be able to understand that benefit that's derived. Now, we're going to talk about Bayes' theorem. It's really important that you understand this in principle. Now, the post-test probability of someone having a disease is determined by the disease probability before the test and then the probability that the test will provide a true result. So let's look at somebody. So I've got James in my office. He's a colleague from Bond, and we do research together. He's 35, I think. He's young, he's healthy, he's fit, etc. No family history of heart disease, etc. He doesn't smoke. So we would think his pre-test probability would be very low, okay? Let's say now James is 72, he's smoked his whole life, he's got high blood pressure, high cholesterol, his parents, all his brothers, sisters, everyone's got heart disease. His pre-test probability of disease is going to be much higher than the younger him. So the probability is related to the presence of symptoms, particularly chest pain, in addition to their age, gender, and risk factors. So here's an example. So a 45-year-old former runner, and he's turned to be a triathlete, wants run training assistance from you. His medical history only includes overuse injuries. But lately, he or she is feeling constricted in their chest when running, but believes it's due to a loss of fitness and strength. But he or she added that their chest constriction is improved with rest, but sometimes they feel dizzy in recovery. So, using the ACSM guidelines, are they currently participating in regular exercise? Yes. Do they have known disease? No. Any signs or symptoms of disease? Absolutely. They've got exertional breathlessness. Desired intensity? They want to get back into higher intensity. Do they need a medical clearance? Absolutely. So with that case study, going back to one of the earlier slides, you can see the patient had signs or symptoms. A medical clearance is required. So it's important that you understand this and that you use this or apply this when you're in practice, because you're going to get patients go, look, I'll be fine, just tell me what I should be doing. Remember, it's liability, and if God forbid something goes wrong, you'll be liable. So this is Bayesian analysis. So let's look at two examples. So the top example is we've got a 45-year-old male. Sorry, we'll use the bottom one. 45-year-old male who has a normal stress test. So that means no ST segment changes. And we can see what's their pre-test probability. So here he's 45. There they have atypical angina, and there they have typical angina. So if we take that age with that risk, you can see that 45-year-old with no angina, etc., has only a 10%. This is all estimated, but you get it in principle. But notice now if that person has typical angina, their pre-test probability goes up to over 80%. Now, let's look at that same patient who has 1 millimeter depression from a treadmill test. Let's call it submax. Before, they only had less than 10%. Notice now that that's more than tripled to about 35%. But notice that person that has chest pain, they do the test and they get ST segment changes. They've almost got 100% likelihood that, or probability, I should say, that they've got coronary heart disease. So it's in principle that you understand this. So we're halfway done with these lectures. What I do to reduce the download time for you, I stop them halfway and then do the second half as a separate lecture. Mahalo. I'll stop now and upload it to Blackboard for you.